Greetings and welcome to this video on Aspergillus treatment. In this video, we'll discuss about the basic principles and the antifungal selection of for Aspergillus group of fungus. So, this is where the knowledge about the azoles and its choices matters a lot. So, why fluconazole is useless and why voriconazole is first line for Aspergillus, we'll get to know in this module. Let's get started. So Aspergillus is basically a mold and not a yeast. Unlike Candida, this is a mold, whereas Candida is an yeast. So it fundamentally differs from the Candida. Any therapy extrapolated from yeast treatment will completely fail. So biology is what dictates the therapy and not the genetic categorization. So it is a filamentous mold of structural complexity with a septate hyphae, angioinvasive properties, and complex cell wall, and grows at the hyphal tips with targeted expansion. So hyphal tips are always the growing regions, and it expands very fast, and it's also very angioinvasive, spreads rapidly. So it's clinically deadly infection because of three properties. One is angioinvasion. Hyphae physically invade the blood vessels, leading to thrombosis, infarction, and hemorrhage. Then host impairment usually occurs usually in neutropenic patients or on steroids. Host immunity is inadequate. Time sensitive delay in effective therapy leads to rapid tissue necrosis. Fungistatic therapy alone is often insufficient. So why fluconazole is completely useless? So when fluconazole is also an azole, voriconazole is also an azole group of drugs. So why can't you give a fluconazole group of drug? It is not about the weak spectrum of fluconazole, but it's about the enzyme mismatch. So basically, these inhibits the cytochrome 51 enzyme fluconazole, but in case of Aspergillus, there is low potency and poor mold activity because of the inadequate binding to Aspergillus cytochrome P51. So multiple Aspergillus cytochrome P51 isoenzymes are present. So when you give fluconazole, it is suboptimal, can lead to even zero efficacy. So it is not used for Aspergillus infections. So voriconazole, the biological mismatch. Why voriconazole has an advantage? Because it is a strong enzyme inhibition at growth sites, which for voriconazole, and excellent tissue level penetration, rapid expansion, potent mold activations. It beats amphotericin in mortality trials as an induction therapy of choice. So why posaconazole, isoconazole exists? So posaconazole has broader mold coverage and higher barrier to resistance. It is used mainly as a salvage therapy, prophylaxis, and for azole resistant strains mainly. So for isoconazole, it has similar efficacy to voriconazole with lower toxicity. It has a less QT prolongation, reduced hepatotoxicity, and reduced neurotoxicity also. So isoconazole is a better drug with lesser side effects compared to posaconazole. So basically, the choice is host driven and not organism driven once aspergillosis is confirmed. So amphotericin, where it's used in case of aspergillus, is that when you suspect an azole resistance, prior azole prophylaxis is already given, intolerance to azoles are there, and it is a breakthrough infection. So direct membrane destruction with no reliance on enzyme inhibition, however, it carries more toxicity and less tissue selectivity. So it is a critical second line or rescue drug. So because of its direct membrane destruction and enzyme inhibition carries more toxicity and less tissue selectivity also, but it often kills the bug. Echinocandins, what is the role of echinocandins in Aspergillus? Mainly Aspergillus is beta glucan, but the drug acts only at the hyphal tips. Mature hyphae are unaffected, so it's just slows the growth but does not eradicate the infection. It's basically a fungistatic at the best possible way. It's not a fungicidal. So combination therapy can be used with an azole and a echinocandin, but only in selected cases. Can be used as a salvage therapy, adjunct in refractory diseases. So never use alone for invasive aspergillosis. So why there is an azole resistance these days? Because of the growing problem, cytochrome P51 mutations often driven by environmental azole exposures in agriculture. So breakthrough infections and prophylaxis, poor response to voriconazole or rising MIC, management functions, class switch to amphotericin, there is considered combination therapy immediately. So all these cases switch to amphotericin. So syndrome specific for invasive aspergillosis, voriconazole is the first line. Chronic pulmonary aspergillosis, it's long-term azole. For bronchopulmonary aspergillosis, allergic bronchopulmonary aspergillosis, steroids is the mainstay, plus or minus itraconazole. For aspergilloma, surgery and removing the aspergilloma and give azole. Same organism, completely different host pathogen dynamics is present for Aspergillus. So you must know when to give what group of drug and when to choose the appropriate antifungal. So this is a basic structural table for fumigatus, nidulans, and for generally fluconazole is not given and resistant for all the Aspergillus. Whereas voriconazole can be given for fumigatus, nidulans, flavus, and terreus, but cannot be given for niger and lentulus. So in case of these group of drug, directly go for isoconazole or posaconazole. Even isoconazole is less potent for Aspergillus, only plus or minus. For lentulus, you can go for isoconazole. So, but flavus and terreus does not work with Amphotericin B. Whereas fumigatus nodulans work with amphotericin, the Niger and lentulus can be treated with amphotericin. Echinocandins are basically a fungicidal drug, does not kill the Aspergillus fungus, basically. So, voriconazole becomes the first line. When you suspect Niger, go for isoconazole or amphotericin B, otherwise, voriconazole is the first line. So, if a neutropenic or steroid-dependent patient is deteriorating with lung infiltrates, echinocandins monotherapy is dangerous. You must cover molds adequately. That is the take-home message from this module. Aspergillus is a rapidly invasive mold requiring high-potency mold-active azoles with plus or minus amphotericin for resistance and echinocandins only as adjuncts therapy. So, hope you learned a lot in this video. If you have any questions, do leave it in the comment section. Mastering Aspergillus is a hallmark of an expert clinician. So, once in your lifetime, you'll definitely encounter an Aspergillus infection. You must need to know how to manage it properly and appropriately. So, this module will be helpful for the clinicians preparing for NEET SS, NEET PG, and for MRCP aspirants. If you're new to this channel, do like and subscribe. Let's meet in yet another video. Thank you for watching.